Hey everybody, welcome back to Psychedelics Today. This is Joe Moore coming at you from Breckenridge, Colorado. Today on the show we have Elliot Marseille, who's an economist doing some interesting work around psychedelic health data. And he has a robust and interesting background in health economics where governments leveraged his work to decide where best to put limited resources for the best result for their country. And now we're doing that work in psychedelics, and thankfully Elliot's doing it. So I hope you find this one interesting. If you do, please share with some friends, and we will see you on the other side. Hello, everybody. Welcome back to Psychedelics Today. Joe Moore here, joined by Elliot Marseille. How are you today?
I'm doing great, Joe.
Great.
Glad to be here.
Beautiful to be here in Oakland with you, and excited to dig in. So I'm kind of curious if you could talk about your previous work in health economics and developing nations. You were saying you did a lot of work in Africa. Is that right?
Yes, some in Africa.
Mm-hmm.
Yeah, after I finished my master's work, I was the country representative for the Seva Foundation in Nepal for 7 years. So Ram Dass was one of my bosses and very brilliant.
He's a tough boss.
Well, he was actually. I mean, he had a very tough-minded side to him, and I say that with appreciation. It was like he was totally reality-based. And he also had access to a broader reality. But anyway, so I was in Nepal for 7 years doing public health ophthalmology, lots of cataract surgery. Of course, I wasn't doing it, but I was supporting the ophthalmologists in doing that. And then I returned to Berkeley and did my doctoral work. I figured I'm doing all this global health work. Maybe I should dig into it seriously. And one thing led to another after I finished my dissertation, and I started working on the economics of HIV/AIDS in developing countries. And of course, much of that was in Africa. So Africa, South Asia. And that's what most of my career has been on, is the economics of HIV treatment and prevention. And I branched out into other diseases and conditions, and also shifted some of my work to domestic rather than overseas. But that's what I did for my career, I could say, for most of my career. And then I had a meeting with, so I'm a burner, and I worked at Zendo for a few years as one of their sitters. And a few years ago, there was a retraining of the sitters at Burning Man, and I was there for that retraining. And I saw Rick Doblin standing kind of by himself, like there wasn't a big crowd of people around him, unusually. So I thought this was an opportunity to go over and introduce myself, and so I did, and I just acknowledged this, told him how much I admired him and the work of MAPS and so on. And it was kind of great because he could very easily have just said, "Great, thanks, man," and gone on to talk to somebody else. But it was Rick. And so, he actually engaged me in conversation, and he did this strange thing. He actually seemed to be listening to me. And anyway, we just got to talking. And at one point, he asked me what I did for work. And so I said, I'm a health economist. And he said, "We need you," like those 3 words. And I said, "You got me." I mean, I was at a point in my career where I really could take on other work. I was actually looking to kind of phase out a lot of my ordinary work. So it was perfect timing. And so I started consulting with MAPS at that time, and one thing has led to another since then. Yeah.
That's amazing. So I'm a little curious to learn a little bit more about the HIV work, like tragically horrible situations in Africa around HIV/AIDS.
Yeah.
And I imagine we've made a lot of progress.
Oh, yes. Right. So incidence has dropped dramatically, and some of the worst outcomes that were sort of anticipated on the terrible trajectory that we had been on have been averted. And of course, much of that is attributable to the advent of effective treatments for HIV. When I started, there were no drugs. It was all about prevention. So a lot of my early work was on, sort of trying to quantify which prevention interventions was the best value for the money. So, the government of Uganda has X number of $1 million to spend on HIV prevention. What should they spend it on? That was the kind of question that
sounds simple, but
right. Well, right. The hard part is modeling the effect on the epidemic, right? Because you're projecting forward in time and making assumptions about your transmission rates and who's going to be affected by it and so on. So that's where the sort of the more technical side of it comes in. And there's a lot of uncertainty.
We spend X on education plus these drugs, perhaps these things kind of converge in a helpful way.
That's right. Yeah.
That's fascinating. There's just so much depth to the HIV/AIDS conversation around Africa. It's like it's not a shallow conversation.
No, it's not.
No. And is there still a pretty substantial place for health economists doing work like this worldwide?
Yeah, I mean, I think increasingly the economics is being recognized. I mean, back in the old days, if an intervention, a drug or therapy or some kind of preventive activity was found to be effective, it would be like, great, it's effective. And the implication is, therefore, we should do it. And we've come a long way since then. It's like, yes, it's effective, but is it cost effective, i.e., is it the best use of the available money? Or, it's like bang for the buck, to put it crudely, but succinctly. Like, where are we going to get the most value for the limited dollars that we have? And that's the overarching frame of us economists. That's why they call it the dismal science. There's not enough money to do all the good things that you would like to do. And so the question is, how do you optimize? How do you confront the trade-offs and make the kind of trade-offs that will result in the most good being done, given you can't do everything?
Even though we want to. And so where were you focused? Uganda specifically, or were you kind of broad?
Including Uganda, but other countries as well. South Africa, Zambia, Kenya for sure, like that. Yeah, and also India and other countries.
I actually never considered the HIV situation in India before for some reason.
Well, it was one of these good news stories because at the time, Africa was being so severely affected. And epidemiologists were saying India is a disaster waiting to happen. Highly populated country, very dense urban areas, lots of people at high risk for a variety of reasons. And, they sort of were predicting an African-style epidemic in India, which, given the population of the country, would have been just absolutely catastrophic, tens of millions of deaths and so on. That didn't happen. I mean, they were affected. I don't want to minimize it, but nothing like what was feared. So it was sort of interesting success story in terms of staving off what could have been a truly, truly catastrophic epidemic.
It's amazing. And similarly, education plus drugs.
Hard to say exactly what caused what, but yes, certainly prevention. And then with the advent of the drugs, that made a huge difference, of course. Yeah.
I suppose before we start talking psychedelics, I want to bring it back domestically. So you probably know far more about HIV/AIDS than I ever will. How are we doing domestically here in America? I hear it's not perfect.
Yeah.
But we've made a good amount of traction.
Yeah. So, I mean, this is where... So I can't give you because I'm not following it that closely now.
Sure.
I've been working on psychedelics the last few years, so I can't give you up-to-date statistics. But the number of positive people who are on treatment is very high. And the number of people who are on treatment who are virally suppressed, that is, they have good adherence and they're really responding to treatment, is very high. That's a nice, how's that for a number? Very high. And so, and as you probably know, when people are virally suppressed, the chances of their transmitting onward are approximately zero. So that's what we're seeing. We're seeing, I don't know how to exactly we want to characterize, but a well managed, well controlled, endemic situation here in the States.
That's amazing. So it sounds like we're just doing so much better than we were. And I was chatting with some folks the other day who are they're still having to raise tons of money for AIDS work in a charity fashion, which is a little tragic. I would imagine the country would want to support that, but we have a troubled past on this topic.
Yes, we do. And, I was speaking very broadly about the success, and certainly within some high-risk groups and some parts of the country, it still remains a big problem. I don't want to minimize it. But it's also good to see the part of the glass that's half full.
Oh, absolutely. Yeah. Like, so much better than we have been doing.
Yeah.
Obviously with just about everything. Always some finishing touches. Sometimes a little more than that.
Yeah.
So let's start talking about psychedelics. I think a good first step is talking about how they entered your world, your orbit.
Yeah. So I was raised in Berkeley. My father, who was born in 1901, was a Orthodox Freudian psychoanalyst. And so I'm guessing a little bit about the years, could be off by 1 or 2 years, but sort of around 1961 maybe, or 62, he got a supply of LSD, I assume from Sandoz. I don't think anybody else was providing it. Yeah. And was treating his patients with it. And he saw it from, he was, like I mentioned, he's Orthodox Freudian psychoanalyst. So for him, it was about uncovering repressed, unconscious material of trauma, or because this is a theory, right? And that present day neuroses arise from repressed memories that you don't have access to ordinarily. Anyway, so the idea was that LSD would provide access and thus accelerate the psychoanalytic process and integrate this repressed material into the ego and so on, like that. Right? I think this is a rough representation of kind of
pretty fair for Freudian. Yeah.
I'm doing my best here. I'm not an expert on Freudian analysis. In any case, that's what he did. And after my parents divorced, he and my sister and I had dinner every, Friday evening. I don't know what it was. It's called Friday evening at Laval's restaurant, Northside in Berkeley. And I remember this very well. I don't think my sister was with me that night. I think it was just me. And he was telling me about LSD. And I was like 8. And he was telling me about LSD and kind of how magical it was. And he said he wanted to give me some. And I was very excited about that. I was like, I'm going to have this adventure with my dad, And I came home and told my mother, Daddy's going to give me LSD. And she said, I don't know, I can't recall exactly what she said, but she told me years later that she contacted him and said, you are not doing that, or I will call the police. I mean, it was just like, this is not happening, And understand, this was early days. This was when it was still legal, and it was before the war on drugs and all of that. So I was disappointed. But he told me about his own experiences, and so it captured my imagination. Like, so, for example, we had this in his house, he had this big painting by Peter Bruegel. I think it's called The Dance of the Peasants. So it's a scene of these peasants. It's like revelry and food and drink, and they're dancing in the square. And there's a red banner that hangs out of one of the buildings on the square. And my dad said that under the influence of LSD, he saw this painting, get this, as the retreat of Napoleon's army from Moscow, and this red banner was flames, from the war, right? It's all this. And I just thought, that is so amazing. How could that be? I'm just a little kid at this point. So that's my first sort of contact with LSD. I was just at that age, just listening to my father talk about it. Yeah.
Do you remember any particular story that was fascinating?
Well, the one I remember most vividly is the one I just recounted about the Peter Bruegel painting. I also know that he called me one time on the phone. Again, I'm like 8 or 9 maybe, and he was not coherent. And I understood that he was stoned. I mean, I didn't have words for it, but it was, that wasn't great. I have to say, it wasn't great. It was like, it was a little disconcerting to me. And I talked to him years later when I was like 14, 15. And for him, all of the other effects of the psychedelic experience were irrelevant. They did not register for him. The only thing that was meaningful was its potential to uncover traumatic material. And he's not wrong about that, but it's interesting to me from my perspective now that he was able to just kind of filter out all the rest of the phenomenology that's available from the psychedelic experience. Yeah.
That's amazing. So where did this kind of develop to next? Like there had to be a second act.
Yeah. Well, like I said, I was raised in Berkeley, and it was just in the culture. And after I was in Europe for 2 years of high school, I came back and finished at Berkeley High. So this is 1970, and all my friends were.
That's the thick of it.
It was the thick of it, absolutely. And my friends were using psychedelics, and so was I. So I just started really in the most, I don't know, Joe, the most kind of naive way. I just thought it was interesting and fun. And honestly, nothing bad happened to me. It ranged from sort of inconsequential to interesting and fun, but also not consequential in the sense of I did not come out of it like with a deeper understanding of myself or the universe. It was just kind of a wild experience. Mm-hmm. And I didn't really have a bigger frame to put the experience in. I mean, I was reading some Eastern philosophy, so I didn't have kind of a framework which might have supported me in having it be more meaningful. And that changed when I had a couple of things changed. One is I did the S training. Are you familiar with that? Yeah, it's now landmark education. I did the S training in 72, so very early on. And the first time I took a psychedelic after that was completely different. It was like, oh, now I get it. Now I understand what people are talking about. The talking about being something like the unitive experience, something like a non-dual state, something like a state of in a completely unreasonable, irrational, but absolutely direct way of knowing that everything is really okay. That experience. And so after that, my experiences with psychedelics were much, much more profound and much deeper. And that accelerated when, so now we're something like 1980 or so. And I had a girlfriend. And as we were getting to know each other, I mentioned that psychedelics was part of my life. And she said, "Oh, you might want to meet my friend Leo Zeff." so I didn't know who he was, right? And so one thing led to another, and I did a session with Leo, and I figured I'm in the hands of like a professional, like a pro here, so I'm going to go for it. So he liked to give acid in conjunction with yahe. So some yahe, I can't remember the dose, but I asked for 1,000 micrograms of acid. It was 750 followed by a 250 booster about an hour later.
It's a long day.
It's a long day. I just figured I'm going to go for it here. And it was absolutely extraordinary. He was, for people who didn't meet him, he was kind of like a kindly grandfather. He wore polyester pants. And while I was having the experience I was having, he was watching daytime TV with headphones, so the noise didn't disturb me. But he just figured he's in here for a long day, and he's just going to watch TV. And obviously, he was totally available to me as I needed him. And I recall at one point, I was in a jungle in South Africa, and I just had this idea that I wanted to talk to Leo. And I took my eye shades off, and I looked him in the eye, and I said, "What would it be like to have a conversation with you?" And he said, "I don't know," which was like I know.
It's fair.
Exactly. It was kind of the perfect answer. He wasn't inviting a conversation. He wasn't shutting me down. He wasn't just like, "I don't know." And I kind of laughed to myself. I thought, that's a perfect answer. Anyway, as I put my eye shades back on and went back into my trip. Anyway, he was extraordinary. Yeah.
Amazing. And since that was a really robust experience for you, was there any kind of, this was really the term integration, was there any kind of like integration window for you after, or did you just go right back at it?
No, there wasn't any integration. I mean, he was, so I don't recall, Joe, exactly.
More so about your experience, less so like what he's offering.
Yeah, right. So he was definitely available to me for questions. I don't recall that I had any particular, the experience was, again, just one of, there's no reason to take 1,000 mics. You don't need to do that to have this experience. But it was definitely a clear experience of it. Let's just call it an experience of it. And so incredibly useful. And I don't like that word. It wasn't useful. Useful kind of sounds like it's a means to some other end, and it's not. It stands on its own as a complete experience.
Yeah, interesting. And it sounds as though you never had like too far out of a relationship with this stuff. Like for a lot of folks these days, they get like pretty, not everybody, but a lot of folks, myself included, temporarily a little far out, and then you can kind of come back and manage your life. Did it ever go that way for you?
Do you mean, when you say far out, do you mean to the point where it was difficult to be in this ordinary consensus reality and handle it well? And
handling normal day-to-day business. And
that's never been an issue for me. And I was
good.
Yeah. I mean, I would say compared to some people, I was using a lot, but from other people's perspective, it was pretty moderate. So I don't know where I am on the spectrum, but yeah.
It sounds like it. Yeah. And was there a next phase for you, or did you just jump right into the health economist work at that point, roughly? Or
yeah. So the experience with Leo, which I just recounted, was before I went to Nepal, shortly before I went to Nepal. Then I had the 7 years in Nepal, came back, did my doctoral work, and then started working in global health, and particularly HIV/AIDS. Yeah.
So the next phase then would be asking about Ram Dass. So you'd had a lot of these interesting experiences. You start getting exposed to Ram Dass's work.
Yes.
What was the catchphrase there? Just serve? Was that it? Or was it more for the Seva Foundation?
Oh, there was SEV. Yes, Seva. It's a Sanskrit word for service.
Okay.
Right. Mm-hmm. Mm-hmm. Yeah.
Did you just get to start bumping into Ram Dass, or was it like you start doing the work and all of a sudden he's around, or how did that go?
Yeah. So I got to spend some time with him at Seva board meetings, and he invited me to be a speaker at the Omega Institute, where he was one of the featured presenters. But the most time I had with him was he came to Kathmandu to inaugurate a new initiative that Seva had for greatly scaling up the cataract surgery that we were supporting. And he was great. I picked him up from the airport, and I'm driving him back into town. And I said, I made a reservation for you at such and such hotel. And he said, I'm not staying at a hotel. I'm just going to stay with you. He was just like, this is how it's going to be. I said, okay, great. I'm not going to argue with you. And so I had the privilege of having him at my house in Kathmandu for about a week or something. I don't think it was less than that.
Amazing.
It was a good week. And he was wonderful. He taught me how to meditate. I'd been doing some meditation, but I was just I was kind of floundering around. And he actually gave me some instruction, which I have been following to this day in one form or another. And, I just loved being with him. And I will say that there wasn't any friction between kind of his public persona and who he presents himself to be in public and just the way he was every day. It was really a fabulous opportunity. And I'll just tell one story because it's just kind of great. So when we inaugurated this initiative, we had the Minister of Health, and I don't know if the Queen was there. She may have been, because she was the head of all of the non-governmental organizations in Kathmandu at the time. This is like 1985 or 86.
Sounds like a heavy job.
Yeah. And so anyway, there were all these officials, and it was very formal. And, I would present some numbers and somebody else would present some plan, and it was like this. And then there was a break, like a tea break in the lobby. And Ram Dass, there were some of the officials kind of gathered around him because they knew he was an important, famous person. And he broke into the Hanuman Chalisa, which is, a long devotional sacred song to the god Hanuman, servant of Ram. And I was kind of like, is he really doing this? And everybody was kind of like flummoxed at the beat, like, what is going on? This guy's singing, right? And then the Nepalese officials, they just started beaming. They loved it. It was just, of course, it was an acknowledgement of their culture and their religion. So it was actually doing this in quotes, inappropriate thing was totally appropriate. It just broke the ice. And the conference went forward on a new basis, really, that we had this kind of shared experience together. And it was great. Yeah.
Yeah, that's going to be an interesting thing coming in as this Western organization, a little bit alien to the culture.
Yep.
We're here to help.
Yes. Oh my gosh.
Mm-hmm.
Yes. It's kind of an impossible position. But yes, yeah.
Yeah, but what a great intuition to just do that. Great connection. It's interesting. Like the culture had this sort of diaspora, and then it came back to them. Said, "Oh, America, you do this in America, and it's you.
Yes.
Great, amazing."
Yeah, no, I love that, and I mean, Buddhism has taken hold in the United States, and I feel that the United States and our culture, our Western culture, has made some contribution to Buddhism and the way it's practiced and keeping it relevant to who we are now in this culture in this time. So yeah, I love that back and forth. Yeah, appropriation, but like in the very positive sense of appropriation and with respect and contribution. Yeah.
Mm-hmm. Yeah, and Ram Dass, I think, did a lot of that really well.
Mm-hmm.
So let's transition into after you met Rick. He said, "You need we need you," which is a big deal. Rick to say something like that. But it's as soon as I heard about your work, I said the same thing. I said, this is really important math that needs to get done here, and projections that need to get done so that we can hopefully move health in a really good direction. Was there any particular data point that was initially really, really interesting to you in the psychedelic ecosystem?
Yeah. I mean, the data point that was the most interesting was that MDMA seems to be so darn effective for PTSD. I mean, it's really pretty spectacular, the results that came out of the phase 2 trials, which is what I was looking at first, and then the phase 3 trials, which were even more more encouraging. And so I remember I have a a close friend and colleague who is the person who introduced me to the HIV work, Jim Kahn at UCSF, emeritus now.
He's
And
famous for writing some books.
No.
Jim Kahn. Oh, okay.
There may be another Jim Kahn. Yeah, no. He is a widely published and well-known cost-effectiveness analyst in global health and big advocate of single payer as well. Anyway, so when I started getting interested in the psychedelic work, I, of course, wanted to involve Jim. And he's kind of like, he's a scientist. He's like, show me, like, what's like, he didn't have any grounding in sort of what psychedelic therapy might be like. And I showed him some of the effectiveness papers. And he immediately said, this is amazing. It's like, I'm in. Yes, we should do the economics on this. And so that was the thing that was so compelling and continues to be so compelling. I mean, if you look at what's coming out of the trials, and you know this, Joe, you follow this closely as well, it's just, you can't, whatever you think about psychedelics and skepticism about it and baggage from the 60s and the war on drug, you can't, you have to, at a certain point, take the numbers seriously, because that's what we do in this culture. We take the numbers seriously. And I think that, MAPS's strategy early on to generate state of the science, randomized, placebo-controlled clinical trials and present that to the world for anybody to look at and question, I think that was smart. That is the way you make things move in this culture. I'm not saying that's good or bad. I'm just saying, yeah, that's how it works. And I think that was correct. And continues to be, the thing that drives the possibility of making these therapies available.
There was a big kerfluffle in the space maybe a month or two ago. There was some organization.
ICER.
Thank you. I actually have zero idea who they are. I saw this stuff. I'm like, it's not for me. I think they're still going to get through the FDA. But like, what do you know what ICER is?
I do. So first of all, it's a pun. So I'm going to, so ICER stands for, oh my gosh, Joe, I don't think I have the, so I'm going to mangle this, but something like the Institute for Comprehensive Economic Research. Okay, ICER. It's also a pun of incremental cost-effectiveness ratio, which is the final result of any cost-effectiveness analysis. Is the ICER? Is it
That's
a favorable?
funny.
Right, exactly. So, and
are they independent or?
Yes. Okay. So here's their thing is that they are an independent group that assesses new medical technologies. Technology could be a drug or but a new medical innovation, and that they objectively, transparently, and following the evidence and bringing all stakeholders in, evaluate the utility of a new intervention. And back in 2014, Jim Kahn, who I mentioned earlier, and I were invited to be part of an ICER research project that was evaluating the very expensive but very effective new treatments for hepatitis C. A little bit parallel to psychedelic treatment because really expensive initially, but really effective. And so I got to participate in an ICER process, and I was impressed. I thought they did what they claimed their mission and their values were, again, in terms of bringing in lots of stakeholders, dispassionately evaluating the evidence and so on. So I have a little bit of familiarity with ICER, and I knew that they were working on this report on MDMA-assisted therapy, and but I just read about it like everybody else when it came out. I read the report, and so couple of comments. So there were two things that they, so their major finding was they felt that they could not endorse MDMA-assisted therapy as, and this isn't great for those of us who would like to see MDMA-assisted therapy as a medicine. And they gave two reasons, one of which I really think is not very important. The first reason is that the trials on which the efficacy estimates are based weren't blinded. Well, this isn't news. We have known about this and it's been acknowledged, and efforts have been made to try to address that issue as far as is possible. But honestly, how are you going to blind a psychedelic therapy? And so, I just feel like there are many therapies that have been approved by the FDA and were not blinded because they couldn't be blinded. So there's nothing unique about MDMA-assisted therapy. And furthermore, if the fact that it's difficult or impossible to blind was a exclusion, a damning criterion by which you could not endorse a therapy, no psychedelic therapy could be endorsed by ICER. So, I think it's worth acknowledging that blinding is a big issue in this field. But again, what else is new, right? So that was one thing. The other part is much more difficult, and I can't say too much about it because I have no independent information. But Joe, as I think what they said in the report was that they spoke with enough therapists and patients who were in the trials to believe that there was a significant amount of bias, that patients were encouraged to overstate benefits and kind of minimize possible, adverse events or non-response, and that the ICER investigators felt that they couldn't. They said something interesting. We don't know how widespread this is, but we think it's widespread enough that we can't endorse the purported effectiveness of these therapies. And it's a tough one because it's a black box. Who can now verify this? The names of the respondents were withheld, which I understand. And so, but it doesn't seem consistent with ICER's purported values of openness and transparency. By definition, this is not transparent. And I wonder whether there's the possibility of respondents who are willing to step forward and speak with officers at Lykos, and so that Lykos can have a direct, opportunity to assess the validity of these claims. So that's about all I can say about it. It's a black box, it was a little surprising to me that none of the authors seem to have a background in psychology or psychiatry. It's not clear to me that they have much experience with clinical trials, which I find kind of an odd choice. I would have thought it would be psychiatrist heavy. So there's a couple things about that are a little odd. And I don't know what the consequence. I simply do not know, and can't really conjecture on what the consequences of this will be. Obviously, FDA approval is coming up in August, or FDA decision, and I don't know whether they will take the ICER report on board. My guess, and it's just a guess. I'm not an expert on how the FDA works. My guess is that they won't. That they said we've got our own process. And we've been working with MAPS and Lykos for all these years, and they've been following our recommendations and so on. And we're just going to complete our process as it is. So but it's kind of it's the first. You're talking about all these encouraging clinical results. This is the first, and there may have been some others I'm not that aware of, but this is the first prominent kind of questioning of the effectiveness data that we have. And over the long term, the solution is more trials, which are happening, more MDMA trials, not just by Lykos, but by other sponsors and so on. And the truth will out, that the preponderance of the evidence will crystallize around either very good effectiveness or maybe less good effectiveness, but whatever it is, we will know over time whether there's really been significant bias in the MAPS and Lykos trials. And the other positive outcome of this might be that we, the community, and in particular the clinical trialists, really, really take on board that they've got to be absolutely rigorous in the way they communicate about and the way they set expectations about the psychedelic therapy. Yeah.
So transitioning out of the ICER thing, as I understand it, the long-term implications of doing these kinds of therapies at scale, we suspect, will radically reduce psychiatric care costs and hopefully other health costs, right? Because we know depression takes a health toll beyond the psyche. It can impact a lot of things and other conditions as well. How do you like to think about improving psychiatry and then like the extended health outcomes and how psychedelics might be able to play into that in a helpful way?
Yeah. Well, you touched on a really important point that I said we economists, not we economists, as anybody who's interested in seeing the potential of psychedelic therapy be realized, which is that they should, as people's symptoms subside and people actually lose their diagnosis of PTSD or depression or alcohol use disorder or tobacco use disorder or opioid use disorder. The list is pretty long here, as you know. As people do better, one would suspect that their healthcare utilization would go down. And we know, there's literature that looks at the relationship between more and severe conditions and their corresponding health utilization. So, we know that as people with less severe depression consume less healthcare. What we don't know, we don't have any longitudinal studies that actually follows people's healthcare consumption over time after they've had, so we could see pre and post or compared with people who haven't had psychedelic therapy over time to actually empirically document that their utilization goes down. So, because that's
We're not empirical yet.
That's where we're taking literature-based estimates of healthcare costs adjusted for severity, but they're literature-based. They're not like actually looking at people who got psychedelic therapy. Do you see if that distinction is clear? So I'm really interested in doing those longitudinal studies and actually looking at changes in healthcare utilization. And as you say, Joe, it's not just psychiatric. Depression is implicated in all kinds of cardiovascular disease, diabetes, so on and so on. So it's potentially a very big deal in terms of cost effectiveness and how insurance companies will look at psychedelic therapies.
Given we don't have a single payer system, this is like an interesting problem too, because it's almost like they're, I don't know, playing shuffleboard with the costs. They're like, oh no, that's yours in 10 years or something, not mine now.
Yeah.
And like I assume insurance companies are looking at economic data because they're playing with such a big pool of money. But how do you think they're thinking about this at this phase? I know it's not approved, but I'm sure they're at least thinking about it a little bit.
Yes. No, it's definitely up for consideration. I think there's a lot of like wait and see, and also you go first, right? It's like there's not some big advantage to being a first mover here. I think that a lot of companies are like, well, let's see how this goes. Let's see if other people do it, both because they might want to see sort of how it works out in terms of efficacy and cost, but also in terms of stigma. Let somebody else go first. So that could be a bit of an issue. And so you mentioned sort of the shuffleboard, or sometimes it's referred to as churning. It's sort of like, well, we're paying for this substantial upfront cost of the therapy, but because people leave health plans in such large numbers each year, somebody else is going to get the benefit. We pay for them when they're sick, then somebody else gets them when they're doing better. And this is an issue. And so it's sort of important to calculate, as one of the things that we like to do in our models, is when is break even? How many years out do you have to assume that benefits are durable before savings start to accrue? So that's important. But remember, almost all health interventions in this country are not cost saving. They're cost effective. Well, some of them aren't even cost effective. That's a whole other conversation. Right. But let's just say, most most interventions are not cost save. They don't save money, but they provide value for the money, i.e. they're cost effective. So people are doing better, but you end up paying for it. So this idea that psychedelic therapies need to save money early on, yeah, it's a standard that's not applied elsewhere. So I question whether that's going to be the criterion that,
right.
You see what I'm
that
saying?
Makes it, yeah, okay.
Yeah. I mean, it's like cataract surgery. It's not cost saving. It's just really good value for the money. Triple bypass surgery in an 80-year-old. It's not cost saving. But we've decided as a society, that's a good use of money.
Right.
Yeah.
That's interesting. Now, in terms of the literature you've seen, are we seeing kind of beyond Lycos, this is like a larger question. Are we seeing cost estimates that range anywhere from like $3,000 to like $30,000 for intervention cost? It's a big spread.
It's a huge spread. Joe, I'm sighing because...
How expensive is chemotherapy or something, right?
Oh, yeah, no. Actually, I'm sighing for a different reason, which is I always have to preface what I'm about to say with a bunch of caveats, which is I don't know. It's like, what's the point of me as a health economist about to say what I'm about to say, which is I don't know what the therapies will cost. And the main reason I don't, is that I don't know what Lycos is going to charge for the MDMA. They may not have decided yet, but they're certainly, whatever it is, they're keeping it, under wraps for understandable reason. But I have, good reason to believe from talking to a lot of people, including people in MAPS, that it could easily be 50% of the total cost of the therapy. So significant.
I didn't consider it that high.
Yeah.
Wow.
Yeah. So it could be in the range of sort of $20 a milligram. So $3,000 a dose ish, in that range. Yeah, I know. I see the expression on your face. I wish the listeners could see.
I don't know that I could pay that much.
Right.
Knowing what I know, but I understand that people that need it in a really, clean clinical environment, absolutely.
Right, and that's why it's so critical that third-party payers get on board now. But just because it's expensive doesn't mean that it's not cost effective. It is cost effective, and it's even likely to be cost saving. A little bit like, I was talking about the new drugs for hepatitis C. People were shocked at the cost. It was like, if I recall, it was $80,000 for 2 pills, like $40,000 for 2 pills. But it was a cure. It turned out to be a great use of money for most patients, or a large portion of patients with hepatitis C. And the cost has come down since then quite considerably. But anyway, my point is, just because it costs a lot doesn't mean it's not worth it. But it's still shocking. There is just this kind of, especially if sort of have some idea of what it might cost on the black market, which is like, 1.5 orders of magnitude less. I mean, it's just, so yes, you had this range of 3,000 to 30,000. Yeah, it's sort of coalescing more like around maybe 20,000.
That's interesting. Do you know of anybody doing work on the economics of the underground? Because that's an interesting question, because I think as the above ground solutions will scale, I think proportionally we're going to see some interesting traction in the underground as well at a substantially lower cost. But there's a lot there. It's a very complex topic.
Yeah. So to answer your question directly, no, I don't. And nobody on my team is looking at that in any kind of rigorous way. I could well imagine that if costs are as high as sort of the numbers that we've been talking about here, that there'll be all kinds of interesting hybrid ways of accessing this therapy, where people buy high quality black market MDMA and either bring it to a therapist, or the therapist finds it, or There could be a lot of, and of course, people going out of country. So there'd be a lot of variations. I really, but I do want to return to this theme for a moment of just the importance of getting above ground payers to get on board with this, particularly Medicaid, for two reasons. One, it's the largest insurer in the country. I think 84,000 people receive benefits from Medicaid. Million, not thousand, something like 84 million people. And disproportionately, it's people who suffer from the disorders that psychedelic therapies address. Really important to provide Medicaid with the numbers and the contextual information they need to move forward with that. And it'll be a state-by-state battle because each state has quite a bit of autonomy on how they administer their Medicaid program.
Wow. Can you describe Medicaid for folks who aren't familiar, international folks and otherwise?
Yeah, so Medicaid is the federal health insurance program that supports low-income people who cannot afford private insurance. So it's huge, and it's administratively complex. It's funded by the federal government, and the state contributes as well. And the state has a lot of, unlike Medicare, the states have a lot of say about what is covered and how it's covered and who has access and co-pays and like that. So, right. So that's why I say it's going to be a state-by-state issue getting Medicaid on board with this. Yeah.
Have you heard of anybody from Lycos talking about Medicaid yet?
I know that they are thinking about it. I'm not in direct contact with them, but absolutely they are. Yes.
So beyond Lycos, what are you interested in that's coming down the pipelines?
Yeah. So we're working with Matthew Johnson at Johns Hopkins on the economics of psilocybin therapy for smoking cessation. And we're getting pretty close to having a paper ready to submit on that. So I'm excited about that one. I mean, a big time public health, right? Smoking, right? Right.
Still.
Yeah. Yes, still. Right. We are about to, we have a paper under review. Lead author is Anton Avicenna at the University of Texas on the economics of psilocybin therapy for treatment-resistant depression. And we will be following that using USONA's data on the efficacy of psilocybin therapy for depression, not just treatment-resistant, but depression. We're working on a model for opioid use disorder. And our goal with all of these models is to make them publicly available. We see this as a public good. So our intention is to make state-of-the-art cost-effectiveness models available to any qualified researcher with support, with manual, and I'm envisioning sort of a council of wise people who will update the model as new clinical data becomes available. So I'm really excited about that. About
kind of like an open source toolkit almost.
That's the idea. That's exactly
and this
right.
is what your group is kind of working towards?
We're not working on it yet. That is to say, we're not actually putting the models out there on the web, but we want to. We are looking for support to do that. I'm actually very, very excited about that. Another thing, which is it's not in the bag yet. No contracts have been signed, or no documents have been signed. But we're working with PHEI, the Psychedelic Health Equity Initiative, on providing the cost and outcome information on 2 pilot sites, one in New Mexico and one in North Carolina, that will be bringing psychedelic therapy to marginalized population, to traditionally underserved populations. Yeah, I'm excited about this because we all agree that this can't just be for affluent white people, to put it directly. This is, if this is going to make the difference that we all want it to make, we need to be able to bring it to people who have been underserved. And PHI is leading the charge on that. So it's a broader initiative, which I won't try to describe, but our piece of it is to understand, working in these pilot sites who have a record of outreach and collaboration with community groups that serve this population. So the question is, how do we bring them into psychedelic therapy, or how do we bring psychedelic therapy to them, given the cultural barriers and so on? And the job of our group is to find out what that costs and what outcomes one gets from it. I'm really excited about that because it's again, we all pay lip service to it. I'm not being cynical here. I don't mean lip service. I mean, people are sincere about it. But here's a case of actually doing it.
Actually testing.
Yeah.
I love the New Mexico angle. That's really important, I think, for a lot of reasons.
Uh-huh.
So I would love to be in touch with those folks. That sounds really fascinating, PHEI. Yeah, just scaling that and doing that research is so essential. And I love that you were able to access the USONA data. That's really helpful.
Yeah.
So another issue that's really interesting to me is this balancing act between collecting the data and then privacy, and can we actually have anonymous data, and what kind of personal health information do we need to keep really secure, to keep people safe? There's some interesting conversations about data collection in Oregon and Colorado in those legal frames, and the idea that before we have any sort of federal legalization, the risk that people might be put under in terms of having losing your federal job or putting your custody of your children at risk, things like that, seem like really robust issues. Have you seen anything like that around privacy? Or
so that's not near the center of the bullseye of my interests, except to say that of course people's anonymity needs to be protected. We never receive information where there's any identifying information.
Great. Yeah.
And when we're, from our side, just our piece of it, and when we're done with the analysis, we destroy the information. So, so I don't think there's a concern there. But yeah, no, you're right to point it out. There is a broader concern. We kind of forget in the bubbles that you and I, Joe, live in. It is still illegal according to federal law. So protecting anonymity just needs to be, needs to happen.
Right. And I'm kind of curious, we'll kind of work towards the end here, but I'm sure you've seen a lot of interesting economic data. I'm kind of curious about what are some of the biggest data points you've been exposed to in the last couple, year or so that's really knocked your socks off? I assume there's at least one.
Yeah. Well, this isn't exactly a data point, but it's something that's been emerging. Two things that have been emerging from the clinical work, which have important implications for cost and access. One is, it may be that people don't need to taper off of SSRIs to get the benefit of. This is huge. And I'll tell you, I'm confused about it because I'm reading the papers, and some of these recent studies seem to suggest that people without tapering do as well or better than those who tapered. And when I say I'm confused, I just mean that it was kind of a given truth that people had to taper. And so now that's being rethought. And that has huge implications for access because, not everybody can taper safely or is willing to taper. And so it just lowers barriers to access and lowers costs. So that's huge.
Big one. So the sense I'm getting is that you're very hopeful here, but we need to get empirical with what we know.
Yeah, we got to get empirical. We follow the numbers. Everybody really. That's we just need to follow the numbers and see where they lead. Yeah, and then the other thing that's been emerging recently is trials that show terrific efficacy without therapy, like support but not therapy, and sort of a big question, what's the line between the two? And that's a big subject of conversation, but never mind. There is a distinction to be made there for full-on therapy support. And I'm of two minds. It's Well, that's great. If you don't need therapy, that reduces costs and, increases access, and that's to the good. But there's also, and I'm not a clinician, but just, as an observer of this, really no therapy. Is that safe? And is that how you're going to get the most benefit from the therapy? I mean, I'd love to see, head-to-head trial, of the same protocol, but one just have, support and the other has full-on therapy, and see if there's a difference in outcomes. And that would be terrific. I don't know if that will happen, but
I imagine within a year and a half, we'll see something like that. This is a big conversation now, so I guarantee people are having this conversation.
Yeah.
Like, can we get to that point, though? I think so. I hope so,
yeah.
at least.
I think it's a big enough question. There's enough money on the table with regard to that question that, yes, I hope you're right. Yes, sure.
I have a funny economics question. So as far as I understand, your group is the only group doing this kind of analysis right now, focusing specifically on these psychedelic interventions. Do you expect that this field will accelerate and there will be other groups, and will that be better for the larger data set that we're going to be working with?
Yeah. So I think you're right. I think the Collaborative for the Economics of Psychedelics here at UC Berkeley, I think we are the only group that is dedicated to the economics of psychedelics. Honestly, I'm surprised. I would have thought that there would be more. There's some individual studies that have been done sort of by various health services researchers, but as far as I know, there's not another concerted, or dedicated effort to look at the economics. Yes, of course, people should. I hope other centers will. There's so much work to do. We can't do it all. We're growing as fast as we can. So there's plenty of room for other groups to come in, and it's just, it's healthy competition. It's healthy collaboration and competition in some form. I welcome it. And again, there's so much to do. It's not like we're trying to keep it all to ourselves as if we could. There's a lot of work to be done.
Amazing. And are there any particular champions at the federal level you're aware of who are really taking your work seriously?
Yes, and I sort of need to. I need to kind of go softly there, because it's still a little bit of a risky position to take.
Sure.
So but absolutely there are, of course. And the VA is coming around. There's no secret about that. The VA is coming around. So that's
quite loud.
Yeah.
And there's some interesting kind of like secret working groups inside that are, they're active. They're even using their own VA emails, but they're not like super public yet, which is fascinating to me.
Mm-hmm.
Yeah.
Mm-hmm.
And then finally, so we talked about like the larger costs of larger healthcare costs, given depression or other kind of expensive indications that lead to other disorders or whatever. One thing that I've been thinking about a lot is the climate impact of sick people. Like the more hospital time you get, the more expensive that is, and how that kind of stacks up. Never mind the plastic waste from the medical system is pretty gigantic. So I think the more we can stay out of, inpatient care with like pretty radical interventions, the better we're doing for the planet too.
Oh, nice. I hadn't thought about that.
Downstream implications are big for me.
Right.
Yeah.
Right. Yeah. Yeah. And the other thing is we think about healthcare costs, and of course that makes total sense. But there are many other societal costs associated with depression and PTSD, and some of our more recent analyses have included productivity effects. So people going back to work when they couldn't before. But there's also, particularly with PTSD, involvement with the criminal justice system, with alcohol use disorder, traffic accidents, domestic violence, involvement with the criminal justice system. And the comprehensive cost effectiveness analyses take all of that into account, take a societal perspective. Now, the insurance companies, they don't, it doesn't affect them if people are not, beating their spouses as much, well, actually, so it was a bad example. It could, but I'm just saying, like, if productivity, if somebody's going back to work, that doesn't lower the healthcare costs of the insurer. So we have to have a dual focus, which is what are the factors that directly affect healthcare payers, because we really want to bring them on board. And then from an advocacy point of view, what are the broader societal costs? And I say this, I say this frequently, but I'll share it here again at the risk of, if people have ever heard me say this before, but I just have this vision of somebody sitting before a committee in Congress or a state legislator or some other, high-level deliberative body, and being able to say, look, here's the societal cost of not making psychedelic therapies available. Here's how many lives we're losing. Here's how much unnecessary spending in the healthcare system. Here's how much, spending on criminal justice that could be avoided. And bringing that advocacy forward where these societal effects could really be, very salient. Yeah.
It's amazing. Yeah, I'm very happy you're doing this work.
Thank you.
And it's important. And like Rick said, we need you. We need other economists to step forward too. Like you said, it's important data. And turns out governments and large institutions take economics quite seriously.
It's a numbers game. It is. And, we're playing it hard, and we will be as objective as we can be, because in the end, that's what's going to carry the day.
Yeah. Well, Elliot, thanks so much. Is there anything else you want to point out? Do we miss anything critical?
I don't think so. I mean, I could go on and on about all kinds of things, Joe, but I think we've got it covered. So,
Great.
So thank you so much.
Absolutely. Yeah. Thank you. And I hope we can do more in the future.
Yeah, me too.
All right. Thanks.
All right. Bye-bye.
And there you have it, everybody. Elliot Marseille. I hope you liked that one. I really appreciated this. And he's just a really kind person, and was really just appreciative of him allowing me to record in his home. It was a beautiful little experience there, and hope we can do it again and dig deeper into this topic of health economics surrounding psychedelics, because it's super important. We don't have unlimited resources, and we have to really focus on where we put our attention as a people. So there you have it, everybody. I hope you enjoy this one, and share with some friends, and we will see you on the next episode. This is Joe Moore signing off for Psychedelics Today. See you next time. Bye-bye.